During the OBGYN department meeting in November of 2018, the quality department came to present the 2019 UPIP program. I have previously sent out a PowerPoint that reviewed this program. It discusses the prerequisites to be eligible for the program, as well as the different attributes that are measured. For today's presentation, I want to review how to satisfy the quality metric requirements. The quality metrics represent 20% of the overall program. Listed here are the 11 quality measures that our department is responsible for. We should make every attempt to satisfy these goals for each patient at each visit. However, we are not expected to be 100% perfect in these quality measures. There are different goals for each measures, and these goals can be found in the previous PowerPoint. We should all be familiar with how to satisfy the adult BMI quality metric. However, as you can see here, if the patient's BMI falls outside of the acceptable range, a box will be generated under the QM tab. You can simply check in this box to document that you have discussed the patient's BMI and documented a follow-up plan of care. Here you can see that this BMI quality metric has been satisfied and the care plan has been included for the patient's review onto his or her portal. Tobacco use should be assessed on all patients at every visit. The MA should assess this history when rooming the patient. If a patient is found to be a current tobacco user, smoking intervention can be added to the reason for the patient's visit. Care plans are then generated that are sent to the patient's portal that discuss ways to quit smoking, and this will satisfy the quality metric. We do very well in satisfying the quality metrics for mammogram and cervical cancer screening. However, as a brief review, the mammogram screening is triggered for all patients 50 to 74 years of age who have not had a mammogram screening within the last 24 months. You do need to actively exclude patients who have had a history of a bilateral mastectomy. I think the easiest way to do this is to document history of bilateral mastectomy as an active problem on the patient problem list. Cervical cancer screening includes all patients aged 23 to 64. The measure can be satisfied by the presence of a pap smear within the last 3 years for all patients in the appropriate age range, or by the combination of cytology and HPV testing within the past 5 years for patients 30 to 64 years old. To exclude a patient from the cervical cancer screening, you should document total hysterectomy or hospice care in the patient's active problem list. Both measures are automatically satisfied once the results are received. All patients 65 and older require a falls risk screening once over the course of a year. When an MA is rooming a patient, if the falls risk assessment is outstanding, they should click off fall risk assessment in the reason for visit. This will queue up documentation in the assessment and plan that the screen for falls has been performed. The steady falls risk assessment can be found under the screening tab during the patient's intake. Once all the questions have been answered, the score can be generated. Make sure to discuss a score of 4 or higher with your patient, as they may be at risk for future falls. All patients, regardless of age, need to be screened for depression at least once in a year. The medical assistant can begin by administering either the PHQ-2 screen to routine patients or the Edinburgh screen to postpartum patients. The PHQ-2 automatically converts to the PHQ-9 for any score greater than or equal to 3. A positive result indicates a score of 10 on either the PHQ-9 or the Edinburgh postpartum depression screen. These scores do require documentation of a follow-up plan, which can either be a referral to behavioral health or an order for medication to treat depression. The patient can also be manually excluded by checking the box in the QM tab for the reasons listed below. Here is a quick screenshot of the depression screening tools we are all familiar with. Medication reconciliation post-hospital discharge needs to be performed for any patient 18 years and older who is seen within 30 days of an inpatient hospital discharge. The measure will be triggered at the first visit after receipt of a hospital admission or discharge summary. The MA should add medication reconciliation post-discharge to the reason for visit. Medications prescribed at discharge can then be reconciled with the currently taken medications. By entering the medication reconciliation post-hospital discharge to the reason for visit, satisfies the QM measure and adds coding to the billing that this measure was performed. All patients should be offered the influenza vaccination from October 1st through March 31st. Patients can be excluded from this measure by documenting an egg allergy or intolerance of the flu vaccine into the active patient problem list. The patient can also be manually excluded in the QM tab by selecting one of the drop-down options. The measure itself will be satisfied by an order for the flu vaccine or by documentation of the vaccine in the vaccine tab of the patient's chart. The actual documentation does not need to be received. We can go by the patient's verbal report. These are a few screenshots of the different ways to satisfy this measure. Report of a colorectal cancer screening is required for patients 50 to 75 years of age. Patients can be excluded from this quality measure by adding a history of colorectal cancer or total colectomy to the active patient problem list. This measure can be satisfied by any of the ways listed on this slide. However, it is important to note if the colonoscopy or sigmoidoscopy was done outside of Summit Medical Group, the procedure report must be received and labeled as such and filed in the patient's chart before the QM measure can be satisfied. Finally, our generic medication utilization will be measured. For oral contraceptives, our goal is 75% generic usage, and for our NSAID prescriptions, our goal is 90% generic utilization. A quick note on disease burden accuracy. While this is not part of the quality metric portion of the UPIP program, it does account for 10% of the weighted attributes included in this program. For 2019 in OBGYN, we are responsible for patients with the following active problems: morbid obesity or a BMI greater than 40, and diabetes. When appropriate, it is important to address the problem in the patient's assessment and plan and add the problem code to the billing slip.